And greetings and welcome. Thank you for joining us for the Systems for Action research program and our recurring Research in Progress webinar series. Just in case you're new to Systems for Action or this webinar series, let me orient you just a little bit. Systems for Action is a signature research program of the Robert Wood Johnson Foundation. We've been operating for about 6 years now, and our mission is to study innovative and impactful ways of helping medical, social, and public health systems align their activities and work together to achieve the goals of health equity, reducing disparities in health and social outcomes, and promoting equity, especially for marginalized and vulnerable population groups. We fund studies all around the country, testing innovative ways of helping medical care, public health, and social service delivery and financing systems work together and integrate their activities. And we use this webinar series a couple times a month to hear from a specific research team about the work that they're doing, that's the system alignment strategies that they're studying, and what they're learning. And so that's what we're going to do again today. My name is Glenn Mays. I'm coming to you from the University of Colorado and our Colorado School of Public Health, which serves as the National Program Office for Systems for Action. And I'll be moderating our webinar series today. Just a couple of housekeeping notes. One is that we will have time for questions, for taking your questions that you may have about the study we're here about today. We invite you at any time to submit your questions using the Q&A box that you should see the lower center part of your screen if you're with us on the Zoom session today. Click on that box. You can type in your question at any time during the webinar, and then toward the end of the webinar today, when we get to the Q&A section of today's webinar, we'll get through as many of those questions as we can. The other thing to note is that we are recording today's session, and we will be posting a recording of this webinar along with the slides on the Systems for Action website. So you're free to, we welcome you to access those resources after today's webinar, and also to invite others who may not be joining us in person, but who may have an interest in today's topic. Please feel free to direct them to our website. You can find the recording of this webinar as well as all the webinars that we do on the website. And you may also you may find some other helpful things on the website as well, resources and other resources and tools that are produced through the Systems for Action research program. So we welcome you to do that. It's systemsforaction.org. So with that, I am going to introduce you to a research team that will be touring us through their study, and we'll be addressing the topic you see on the screen. Can subsidized transportation options slow diabetes progression? This is a really interesting study conducted by a research team based in Georgia, led by colleagues at Georgia State University, and in particular, Dr. Fei Li, who we'll be hearing from today as one of the leaders in this study. And we're also fortunate to have several other collaborators in the study with us as well. All of our studies are collaborative and community engaged, stakeholder-driven studies. And so I'm going to turn it over to Dr. Li to introduce some of the other colleagues, her other colleagues who will be with us today.
Thank you very much, Glenn. Hello, everyone. Thank you for joining our webinar. My name is Fei Li. I'm an assistant professor at Georgia University at Urban Study Institute, and I'm the PI of the study. We also have Chris and Renee with us today. Chris is both a co-PI and director of customer insights at MARTA, which is our local public transit authority. And Renee is patient navigator at Subsidized Medicine, based at Grady Memorial Hospital. Both MARTA and Grady are our local partners in the study. So to summarize the progress we're going to report today, The study was initially designed as an experiment. This was before the COVID-19 pandemic. We wanted to test the causal relationship between transportation and health, especially for low-income chronically ill patients. And we designed to test several different mobility assistances or subsidized transportation options for a time period of 12 months. But then we know COVID happened and we had a lot of trouble keeping the patients in the program for the amount of time that we designed. So we kind of modified the study to both adapt to the situation we're facing under COVID and also to use the opportunity to examine many pandemic-related questions, such as how the pandemic have affected travel behavior, including access to healthcare and public health services during this time. So to date, we have surveyed 257 patients with either uncontrolled diabetes or hypertension who participated in this food as medicine program, which targets food insecurity and their dietary-related health conditions between 2020 and 2022. And we conducted both surveys and in-depth interviews for a smaller subset of our patients, which help us better understand the impacts of the pandemic, as well as the mobility options we offered. So to start, we designed the study in order to address the transportation inequity in Atlanta, Georgia, which we believe is also the case in many other communities in the United States, which can be an important determinant of health disparities. So in this map on the right, we see a sharp contrast between the most wealthy and the poorest neighborhoods in Atlanta, pretty close to each other, but you can see a more than 10 years difference in life expectancy and many other health indicators and outcomes. So it's pretty well established in the literature that transportation barriers can be a determinant of healthcare utilization, and it can also affect how people get healthy food and other health-related services. We have these food deserts and public transit deserts, and especially for low-income people and chronically ill patients who might be more dependent on public transit, but these services tend to be inadequate in these segregated neighborhoods. And especially for the target population in our study who tends to be older, and they already have a lot of mobility constraints. And we also know in the past several years that COVID-19 pandemic has added to their mobility challenges. So in this study, we really wanted to test the causal linkage between subsidized transportation or transportation support and health outcomes. To design the randomized controlled trial to compare several different options. We also want to align with the objective of S4A. We want to examine the intersystem gaps that prevent people from accessing and fully utilizing these opportunities and resources between healthcare, public health, and other social services. So the third point added during the pandemic was to examine how travel behavior, including healthcare access, have changed during the pandemic. And to what extent are these low-income chronically ill patients able to use technologies such as telehealth and online shopping and other things to supplement the challenges they face in physical transportation or to avoid further COVID exposure. So we have a cross-sector partnership as every other S4A project. We're based at Georgia State University, and we have close partnerships with MARTA, where Chris is now at, and Grady, the healthcare partner. And we also have partners from like governments such as ARC and nonprofits like ARCHI, which is the collaborative initiative promoting public health and healthcare access. And on the other side, we have these partners for food as medicine, like Atlanta Community Food Bank and Open Hand Atlanta, who work with Grady Health Systems in creating this food as medicine program, which some of you in the audience might be very familiar with. This is an initiative, again, targeting both food insecurity and diet-related health conditions. And in our case, we focused on diabetes and hypertension. So the food as medicine program at Grady, it features both providing for groceries, mostly plant-based groceries. We have biweekly pickup that patients come in twice a month to pick up 2 weeks worth of so-called food prescription from this food pharmacy. And they also offered cooking and nutrition education. You're supposed to take one class each every 3 months. They can sign up for up to 4 3-month episodes. So initially when they enrolled in the study, it is for 3 months. And if they satisfy a criteria of minimum participation during these 3 months, then they can renew for another 3 months, and totally up to a year. The program started in August 2020, so unfortunately it coincides with early stages of pandemic. So the recruitment was not as fast as initially expected, but still, since then, Food as Medicine at Grady has enrolled over 1,000 patients with these health conditions. The target community of the program is largely overlapped with target community of Grady Memorial Hospital, which on this map is pretty much in the center of the city of Atlanta. It mostly serves Fulton and DeKalb, which are the two most urban counties in Metro Atlanta. And you can see here a lot of these neighborhoods are among the most socially vulnerable. These are some of the poorest and most minority concentrated neighborhoods in Atlanta. And this map looks at the concentration of families without private vehicles, and it is very, very much the same as distribution of where Grady patients are from in those socially vulnerable neighborhoods. And this area is also relatively well served by public transportation, including the train and bus networks of MARTA and its adjacent county public transits. So our methodology for the research study based at Georgia State University, we recruit food as medicine patients with transportation challenges. And we offer them with 3 different interventions randomly assigned to 4 groups, including a control group. We have a public transit group where the patients will receive 10 free rides a month, and a cash subsidy group where they receive an equivalent amount of cash, $25 a month. And the third group whose intervention is a mobility counseling group where they receive a monthly solution-focused therapy session, helping them identify transportation challenges and solutions. During the 12-month period, we conduct 5 waves of surveys, asking the patients about their trouble behavior, their utilization of healthcare and other services and trouble modes. And we also adding, this is a response to the COVID challenges, we're adding in-depth interviews for a subset of the patients. Our baseline survey includes questions about their pre-COVID behavior so that we can compare what the impact of the pandemic was. So it's a comparison of the basic participant profile to date. We're comparing the entire food as medicine population and those who enrolled in our study. So as you can see here, we have about a quarter of the food as medicine patients, and generally, if you look at the whole food as medicine population, it is already, overwhelmingly African American, and average age close to 60. A lot of these patients receive food stamps because food insecurity is one of the screening criteria for signing up for food as medicine. About a third being self-pay patients, meaning the uninsured or uninsured, and the similar share of Medicaid and Medicare patients. So these are some very low income, very disadvantaged patients. And if you compare the two columns, our patients are even a little more disadvantaged than the overall food as medicine population, because we are targeting those food as medicine participants who report that they have trouble getting in to either to the food pharmacy or to their doctor appointments. And this is their baseline health indicators. So because many patients with diabetes, so we report the A1C, and it's very high, uncontrolled diabetes. Hypertension is also over half of the participants had stage 2 hypertension when they signed up. And on average, about 10, 11, or 12 days feeling unwell physically in the past 30 days. Similar amount of days being mentally unwell. And majority of patients report their health as fair or poor. So these are some very sick patients as well. And when we compare this basic measure of participation, we looked at patients who signed up over a year ago. So these are patients who were enrolled before November 2021. So you can see a smaller sample because we have about 100 patients signed up after that date. And for the 12-month period after they signed up, we compared the number of food as medicine visits. These include food pharmacy pickups, and nutrition and cooking classes. And we see about average 11 visits for the entire food as medicine population. And if you do simple calculation, the maximum number of visits is much greater than that, because they can come in twice a month for the food pickup. So for 1 year, that is 24 visits already, and plus the nutrition and cooking classes every 3 months. So they could have had a much larger number of visits, but this indicates the challenges in participation we're facing, that a lot of patients either withdraw early or they don't meet the minimum participation requirements, so they are not allowed to renew, or they just don't come in as often as they could. So if you compare these measures, for those who signed up for the GSU study, they actually have a bit more higher levels of participation than the overall food as medicine population. They have more food as medicine visits, they have a little more doctor visits and virtual visits. So it's worth mentioning for doctor visits and virtual visits, these numbers are also way lower than what we expect to see. Because again, these are very sick patients with uncontrolled diabetes or hypertension, so they should be following up with doctors every 3 months or so. But it turns out like over a year, the average number of visits is below 1. So not even ever patients coming in during 1 year period. So despite what we're seeing here, it's hard to say whether this is because of our interventions that we are encouraging or we're facilitating more participation from the participants, because there might be a selection problem. We're only seeking to enroll those people who have the needs, and these might also be the more motivated participants in food as medicine. Maybe that's why they are coming in more often. And on the right side, this table is only for our participants, because we don't have this information for the whole food as medicine population. This is from our survey. So from the baseline survey, half of the participants don't have a car, and over a third cannot drive. Another 8% can only drive sometimes, depending on their health conditions. So driving is not often a solution for these patients. And because of the technology questions we want to ask, we also ask whether they have internet at home or on mobile device, and a substantial portion of these respondents don't have internet access at home or even on a mobile device. So these are some comparisons between their current when they took the first survey versus the pre-COVID situation. Will be asked, what's the situation in a typical month before COVID started, basically before January or February 2020. So first of all, we asked, how often do you have to leave home for any purposes? So we can see here, despite we expect that that the pandemic will prevent a lot of out-of-home travels. We see the red bars showing the current or under COVID situation. So we do see a reduction in the daily travels, almost daily, but a similar increase in a few times a week. So maybe there is some reduced travel demand between among these patients, but it's not by that much. See, very few patients report they never go out or only once a month going out. Most of them still going out pretty much every week, a few times a week. And when we differentiate different purposes of trips, here we only report two, we think, more important types of travels for these patients: grocery shopping and medical related trips. Again, it's not that much difference between pre-COVID and under COVID situations. So here we actually see somewhat an increase in frequency of medical related trips. And for the travel time and travel mode used for medical related trips, again, not that much difference between pre-COVID and the current month. And for travel time, we see most of the patients have to travel more than 30 minutes, and a pretty large proportion needs to travel more than 90 minutes for a medical related trip. And for the travel mode, public transit is the most common primary mode, even with COVID. There is a bit of reduction after COVID, but still nearly 40% of the patients report that they use public transit most often. And we also asked about telehealth, like doing it from home or online, and we do see this number increased under COVID, but still it's a pretty small percentage. As for financial impacts of the pandemic, we see most of the patients are negatively impacted. Almost 40% report that their household income significantly decreased since COVID, and another like 15% saying it somehow decreased, and very few said their income increased after COVID. Almost 30% of the participants saying they are unemployed since COVID, meaning they want to be employed, because many of our patients actually don't work or they're retired, but among those that are looking for a job, many actually are unemployed since the pandemic started. So next, I want to report some preliminary results from our interviews. We have 10 in-depth interviews so far, and we're already seeing some interesting patterns we haven't been able to do. Our target number of interviews would be 25 to 30. And we want to interview both patients who are able to follow through, they either graduate after 12 months from fitness medicine in our study. Also, those who are unable to stay for that long. So those who have to withdraw early or who cannot meet the participation requirements. So we can ask them what are the main barriers or what are the reasons for them to withdraw. So here I want to report the findings around several themes, how they get around, the difficulties they're facing accessing either healthcare or fitness medicine during COVID, and how they're using technologies, or if not, why not? So among the traveling or getting around questions, we see it is important for these patients to plan ahead for any kind of trips. Like these two answers saying, if I have something to do that day, I have to do it the day before, I have to make plans the day before because of these health conditions I'm facing, the pain. I can't just get up and go somewhere. And similarly, this patient is very organized and pretty successful compared to the average participant in our study in terms of getting where she needs to go. And what she's doing is to kind of plan even from a week ahead, just to keep things on the agenda or on notebook and double check what she needs to do to plan for transportation. And many also report lack of transportation. These are two different participants using pretty much the same words. I don't have no transportation. And one is because they don't have money, and the other because her car has broken down. Financial barriers have been mentioned a lot. So what we're offering in our subsidized transportation options, such as $25 a month, is really not a lot. But when we ask them how much they spend on transportation each month, it's actually like $25 can actually be a substantial boost to their transportation budget. Like here, this patient is doing back of the envelope calculation. The cost of MARTA pass, the public transit pass, is very expensive. So most of the patients qualified for reduced fare, either because they are seniors or because of low income status. If they are on some other welfare programs, they can qualify for a reduced fare. MARTA pass, basically it's $1 per ride, but even that can be hard to get for some patients. So if I put 40 trips on the card, I don't know how long that will last. So 40 trips will be $40. And if we say it can last 3 months, well, she doesn't really think it can last that long. If we say 40 trips can last for 3 months, then it's $120 a year, and she doesn't have that kind of money. And this second participant here is talking about finding a solution between public transit and like ride-share services like Uber and Lyft. She can directly use Uber or Lyft because she doesn't have a credit card or bank account. So she has to find someone who can take a small payment and drive her somewhere, but she needs to find someone that's going to charge her reasonably. When they're able to use existing services such as transportation, the non-emergency medical transportation provided by healthcare insurance, or MARTA Mobility, which is a service offered by MARTA for people with limited mobility or disabled people, it is often reported that services are either slow, unreliable, or just don't come sometimes. So, like, here, this patient is talking about using MARTA Mobility because she has a disability. It is often a very frustrating experience. Sometimes she has to wait for hours, and she's talking about the lack of communication between the dispatch center and drivers. And other subsidized transportation options for some of the participants involve a county-offered service, which use rideshare services like Uber and Lyft, but they only used to pay $1 per ride. So sometimes they refer to it as dollar rate or common courtesy. And it is generally more reliable than some other options. So here she's talking about the insurance transportation. I've been having problems with them. They've been making me miss a couple of appointments. And for MARTA Mobility, again, so there are good days and bad days. On a good day, I can make 2 appointments. On a bad day, I'm either late or I just can't make it. And for their own mobility constraints and accessibility issues, they talk about how some MARTA stations, although all the stations are designed to be accessible, sometimes the elevators don't work and there are stairs, or they have to cross the street, which seems dangerous with the walker. They do mention using public transit under COVID can be scary. And one participant specifically saying she's just not using public transit for that reason, because she has immune system issues that she just want to avoid exposure at all. And because of that, she can't even use some of those options offered by insurance, because those will also be shared vans. And other participants are taking different approaches, such as this one. In the beginning, it was a little scary, but then she just got used to it and do all the precautions she can. and continue to use it. We also have some positive perspective on the traveling experience or making trips, despite the time consuming or the inconveniences. Like here, this participant is talking about using MARTA. Like she has to walk a lot, but she's kind of enjoying it, partly because getting exercise, but also because that means she's able to walk, she's living relatively independently. I would thank God that I'm able to walk and be in the right mind, and I was going somewhere that meant something. And here another participant talks about feeling happy when she's having to go out, although it might take a lot of time to go to a hospital. But still, it's like taking a tour in Atlanta. Otherwise, she's not getting to do much at home. You see the different new places, the building, meeting people. It's nice. We do have many reports of facing challenges because of provider changes during the pandemic or difficulty in making appointments, seeing the doctors they used to see. So sometimes the doctors leave, doctors are sick, they're not there. And of course, it comes with a cost of finding a new doctor, and sometimes the new doctor don't necessarily understand your problem, and you have to change again. And scheduling can be also a disaster. So it used to be easy, like this participant said. It used to be easier to make appointment, but now you have to call in. It's like month waiting. And here, this is like a coping strategy or a response to difficulty of transportation is trying to clump all the appointments she has to make in one day. But of course, that's sometimes not possible because of the availability of doctors. Then we asked about why they leave food as medicine for those who did not stay in the program for the full 4 episodes or 12 months. So the first 2 answers here involve transportation to some extent. We do sense that transportation can still be a serious barrier to both healthcare and programs like food as medicine. So this first participant said, because I got sick and didn't have no transportation to get there. And the second was like, she wasn't really sure why she left, but she did say it was a problem getting the groceries home, especially because she's using bus to get there. And here we do have like a happier example of why people stopped coming, because she had got rid of the symptoms, or she got her blood sugar under control and she felt like she didn't have to come anymore. Then lastly, we asked questions about how they were able to or not able to do things online and how they felt about it. Of course, first we asked if they were able to use telemedicine or telehealth to see a doctor or to keep up with their appointments. And we have mixed responses. Some patients say, yes, it's convenient. But here we have 2 responses saying they don't really, either they don't like it or they just are not that computer savvy or tech savvy, and they're not fully comfortable with stuff like that. This is the interesting response here. It's not entirely about telemedicine per se, but she was talking about medical gaslighting, which can be a common experience for especially African-American females. Most of our patients are Black females, and they do feel like sometimes doctors don't really listen to what they have to say and just tell them they either have a condition or they don't have a problem, even if they're feeling it. So this participant here had a more positive experience with telemedicine, other than more traditional types, just a phone call to follow up. And this one here was appreciating people or these nurses or physician assistants checking on her. And here we have an example of certain medical conditions just can't be addressed with virtual visits. You have to see the doctor. When we ask about online shopping or getting groceries delivered so they can avoid going to grocery stores, which can either be risky during early COVID outbreaks, or it can pose additional transportation challenges. We actually get a lot of responses in not trusting those services or not knowing how to use them. Like this participant here saying the apps on her phone just wouldn't let her do it. And the interviewer didn't fully understand what she meant by that, but she didn't think she was able to use any of those delivery services. And then she also said, I don't know what Amazon is. It's on her phone, but she doesn't really understand. And she could have asked for someone to help her figure out, but she doesn't want to give them all her information in order to like sign up or to register a payment card or something. And similarly, this other participant was like, I don't like shopping online because it's like you're putting your information out there and they hacking into everything. So it's not secure. So to conclude, we're seeing that despite the inconvenience in riding public transit during COVID and also the service disruptions, public transit remains important means of transportation for these low-income chronically ill patients. Therefore, it is more important to guarantee that they have protection they need and they can afford the service. We also see that transportation is still a significant challenge in obtaining medical care and participating in FIDES medicine. Despite the many options many of these patients already have, such as the insurance, transportation, or common courtesies provided by county for seniors. And they have pretty limited knowledge or trust of and access to technologies. So in the past few years, we see expansion in application of telemedicine and other virtual services. But for this patient population, it is rather slow, or some of their needs just can't be satisfied by these services. And going forward, we'll continue to follow up with our current participants. We have stopped initial recruitment, but we still have about 100 active patients in the study. And we expect them to finish the 12-month period before the end of summer 2023. And we'll continue to conduct more in-depth interviews, especially with those who have left the program early. All right, thank you very much. And now we can hear from Chris and Renee from MARTA and Grady's and FIDES Medicine's perspective. Chris, do you want to start?
Sure. Hi, everyone. My name is Chris Wyczałkowski. I'm the Director of Customer Insights at MARTA. I'm also a co-PI on this project, which Faye and I started when I was at Georgia State University. My research is around transportation access. And in my current role, I'm focusing on looking at or collecting insights to help MARTA better understand our customers, and when we make decisions about changing service, how those changes might impact our riders. MARTA overlaps with this study both spatially, in that our service area very much aligns with Grady's service area. MARTA, the Metropolitan Atlanta Rapid Transit Authority, covers the Fulton and DeKalb counties, which where Atlanta falls into those counties, as well as Clayton County, which is just south of the Fulton and DeKalb counties. So the service area is the same, as well as public transportation riders. Minority and low-income populations are overrepresented as riders compared to the general population. The other thing that people should understand about public transportation is that we provide public transit, but we're also a community partner. So, for example, we support homeless outreach. We have a lot of homeless that will pass through our system, and MARTA has a program in place to help those people. We also have new transportation options that we're constantly exploring. So for example, we just had a demand response pilot, which is sort of similar to the mobility transit that Faye described earlier, for low-income people who have ambulatory issues, but this was open to any patron that lived within the service area. So the information that we collected, particularly the qualitative pieces that Faye reviewed, really provides us additional data and additional insights into our riders, and again, how we can provide better service to those people. Renee?
Thank you, Chris. And we also have Renee, who's working at the food pharmacy as a patient navigator.
Yeah, thank you, Dr. Fain, for sharing this. I actually really appreciate all the info. One thing I wanted to say is that, like, I've always stressed that patients complain about transportation, that they don't have enough transportation, or transportation this, transportation that. But lately I've realized that a lot of our patients who complain about transportation, it's not like they don't have the transportation, it's more of they are connected to transportation, but a lot of times transportation don't actually come and pick them up. That's what I've learned lately. So whether they get it through their insurance company or they call Uber and Lyft, the actual transportation bus doesn't actually come and pick them up. Or they actually come very late to pick them up, so they miss their appointments. So I just want to say that. But overall, all of our patients really appreciate the Georgia State study. They express their gratitude. It helped them so much, regardless of the group they were placed in. So I appreciate you guys for doing this for our patients. Some patients are still asking, are you guys still taking people, by the way?
Thank you, Renee.
Thank you.
Fantastic. Well, thank you so much, Faye and Chris and Renee. Really interesting work here and lots of important insights gained through this study. We are now open for questions. If any of you who are with us on this webinar would like to ask a question or hear a bit more about something that has been discussed by our panelists to date, we welcome you to do that. Please submit your question using the Q&A box, which you should see the icon for down at the lower center part of your screen. Just click on that, type in your question, and we'll be glad to get to as many of those as we can. And just to kick things off, I guess I might ask panelists in terms of your thinking and learning around the idea of subsidized transportation options and kind of what role that may play in addressing some of the barriers and needs here. Do you have any advice or insight about how healthcare and social service systems should be thinking about subsidizing transportation options as a way to try to meet more of these needs going forward?
So to answer Lauren's question on prescription medications, this in our survey would be included in the medical related trips. We did not separate this from going to see a doctor or a therapist, but we certainly could ask more specific questions in the interviews. I think one thing we would be more interested in, especially given our COVID related questions, was to see if they were able to use some of those online or delivery services to get prescription drugs. But so far, no, we haven't included that specific question in the survey. Renee, would you want to add on that? Do you have more information on how they're getting their medicine?
Grady has two pharmacy, outpatient pharmacy and the senior care pharmacy. So I believe a lot of the patients that actually come, they usually will go to the senior care pharmacy when they're here, assuming the medication is filled, and just pick up their medication from here. And I believe, I want to say they get like I've heard patients say they get discount on their medication. I don't know if that's for everyone, but there are a few patients that say that.
So about the question on any early information to share about results, participant feedback on the 3 different study options. I would say we haven't, so we're reporting here, we're lumping all the 4 groups together. And these are for patients who either completed or their time window of completion is over. And we have about 100 active patients right now who haven't been in a study for long enough to assess the results. And given the smaller sample size, so our originally targeted sample size was about 120 patients per group. And for now, we have only like 30, 40-ish per group that completed. So we haven't been able to do a really good analysis between the groups, but from what we see earlier, just looking at participation, we definitely see a higher retention rate for the cash group compared to all the other groups. And I guess that's not surprising. So we actually changed the group assignment a bit since, I guess, May 2022. Yeah, in May 2022, we were kind of analyzing the early data and seeking to make the biggest impact with our remaining budget. So we got approval from System for Action to slightly modify the project. So going forward, our new participants will only be put in either the MARTA group or the cash group. So we try to maximize the benefits we can deliver to the patients, but the final results, we still need more data to be able to do intergroup comparison. What prompted the interest around transplantation and diabetes management? So like Chris said, Chris and I, we were always interested in transplantation and accessibility. So we wanted to look at healthcare accessibility, and we initially weren't really targeting diabetes or any single medical condition, but we want to look at people who have chronic conditions that they have to seek routine care. So that means they will have pretty consistent needs for transportation to healthcare facilities. So when we established a partnership with Food as Medicine, because we talked with the Food as Medicine team when we were designing the study, and we sensed there will be a great partnership, and they were thinking of diabetes, and we think, yes, that will be definitely one of the patient populations that need this kind of interventions or studies. So that's how we formed the partnership. Have you thought about how these findings would be similar or different if you work with a more rural population? Definitely, because yeah, like Chris said, our target communities are very much served by MARTA and those other public transit agencies in the region. And if we were to work in a rural setting, I think at least for one thing, we would not see as much of public transit dependency, and we might have to devise other options of transportation. Chris, do you want to add to that?
For the rural piece, just that, as Faye said, public transportation really doesn't reach into rural areas simply because the population density is so low. You just don't have those efficiencies. And secondly, on that note, you could add the issues with rural hospitals where they're closing and people have to go, further and further to get medical care. So I think that there is definitely a need for transportation assistance for medical care in rural areas, but it's a slightly different, will be a slightly different study again, because the public transit is not available to the same extent.
So maybe related to that, I want to mention that our original design of this study also included a fourth research arm, which would be using rideshare credits, which is another way to help the patients get around. But eventually it didn't happen because both COVID and our partnership was lifted. Didn't really happen, but we think some of these options would be, or maybe a more hybrid between rideshare and public transit, more on-demand kind of shuttle service would be more relevant for rural or suburban areas. So Anna's question about patients who are wheelchair bound. So this will be similar to the patient with disability that we showed some of her responses in the interview piece. She's not quite wheelchair bound, but similarly, they will rely on MARTA mobility, the door-to-door service for disabled passengers. And these are more expensive than regular MARTA buses or trains. So there will be more of a financial barriers. And of course, they will face more constraint in getting to places where MARTA mobility could not get, or they will have to wait longer for the bus to come to pick them up. And I do think that could be one thing that prevent people from signing up for this medicine to begin with. Renee, I don't know if you have a more general idea about the overall for this medicine population, like how many wheelchair bound, or if any.
Yeah, we don't really have a lot, like a significant number. It's very few. And I try to stress what all the patient would need to complete every 3 months. So they kind of have an idea if, they'll be able to sign up that day. The few of our patients that are wheelchair bound usually comes with someone, or, like Dr. Faye said, they use MARTA mobility. And we try to try to put more than one appointments on one day for patients. That way it's easier. If they're here already, they could just pick their produce up and visit their other appointment as well. But we don't have a lot of wheelchair bound, and the ones that we do have are usually accompanied by someone, or they're actually in a motor chair that they could function on their own.
Yeah, so that's also related to Anthony's question. Do we specifically include people with existing disabilities? Not necessarily. This was not part of the enrollment criteria, but we also not excluding people because of disability. Many of our participants have various degrees of disabilities, some related to their diabetes. I do know, so one of our interview participants, she was on a wheelchair for a while because of a surgery. And it was a point of concern in trying to meet her for the interview. But she's not always wheelchair bound, but no, we don't. I don't think we have a sufficient amount of participants who are using wheelchair, like Renee said, to warrant a subgroup analysis within our sample. But we definitely are capturing their specific challenges in the interviews and to some extent the surveys, I think. When do you anticipate reporting any outcomes or correlation data to understand the impact your patient population health outcomes in the study? So that will be hopefully shortly after we finish data collection by I think August, September 2023. So by the end of this year, we should be able to finish the analysis with health outcomes. Work directly with rideshare vendors. So yes, we wanted to. And we were trying to work with Lyft, but yes, like we mentioned, there were some disruptions first because of COVID, and we had cost limitations. But we do look forward to future studies. Hopefully we can still work with a rideshare or a similar service, because obviously many of these participants do need more options, not fewer. Residency in senior apartments, yes. Many do not have their own transportation and have medical needs. So we do have, thanks Neil, we do have participants in senior apartments. And one thing we found interestingly, especially for patients in the counseling group, is that they actually get a lot of information from their neighbors in those apartments or assisted housing. So it almost feels like they are more informed than seniors living in other settings or in their own house. So for mobility counseling, we are trying to kind of introduce the participants to services available, but maybe they're not aware of. But what we found is for these seniors living in similar settings like senior apartments, they're getting a lot of views already from their housing or neighbors. So they can either use them or they decide it's not for them for various reasons. Concerns about public transit reliability, staffing shortages, absolutely. I think that's a big factor. What we're seeing here, so many complaints about smart mobility not being reliable, and some participants do say that they understand because of what's going on, COVID and all that, they do have staffing shortages and they understand the situation, but it's still not helping them getting to their doctor appointments. Right, thank you for this note. The term wheelchair bound is not usually used in disability community. The term wheelchair user is more appropriate. Thank you.
Fantastic. Well, thank you so much. This has been a wonderful presentation. Great to hear updates from the study. So thank you again to Faye, to Chris, to Renee for joining us and sharing us your insight. Again, this is a study still underway, so hope you will check back with us and with the subtraction program as we continue to learn more from this study and get closer to seeing final results. Thanks everybody for joining us. Again, feel free to check out our website at systemsforaction.org. We'll have an archive of this presentation. You can see many of the other presentations. And don't forget to sign up for our email list. You can get notices on future presentations. We do this webinar about twice a month. And so we hope you'll join us again.